So our model working group was chaired by Anna Bersano and myself, and was composed of 10 experts in cerebrovascular disease, including 6 vascular neurologists. As you know, Moyamoya angiopathy is a rare condition with multiple questions for stroke neurologists. The natural cause is not well known. The prognostic value of vascular and hemodynamic assessment and the need of long-term imaging assessment is undetermined. The pathogenesis is poorly understood. Even we know that there is a strong genetic component in MMD cases related to the RNF213 gene, but we do not know the prognostic value of RNF213 variants. There is no treatment reducing the progression of the disease, and the efficacy of aspirin for reducing ischemic events is undetermined. There is a lack of guidelines for cerebral revascularization surgery, which is used to prevent clinical manifestation. We do not have clear indication criteria. We do not know what is the best technique of revascularization. We do not know what is the best timing for surgery. And we do not know what is the best patient management during the perioperative period. For developing these guidelines, we follow the ESO procedure, which is based on the grade evidence methodology. We identified 9 PICO questions. 3 were dedicated to imaging assessment. 1 was dedicated to the genetic screening of RNF213, and 5 were dedicated to medical and surgical treatment. We identified and rated the main outcomes, and we performed a systematic review of literature for each PICO question before grading the evidence. And an expert consensus statement was provided when there were insufficient evidence to provide a recommendation. So now we will start. First PICO question concerning hemodynamic assessment. In patients with Moyamoya angiopathy, does hemodynamic assessment using the different techniques compared with no hemodynamic assessment improve the identification of patients at higher risk of unfavorable outcome? We had insufficient evidence to provide any recommendation, and the expert consensus statements were as follows. For all patients, we suggest performing hemodynamic assessment during the diagnostic workup in order to help decision-making. In patients with asymptomatic MMA and where symptoms are not clearly associated with hemodynamic triggers, hemodynamic assessment should be performed to identify hemispheres at risk. For patients with clear hemodynamic triggered TIAs or water-shot stroke in one cerebral artery territory, perfusion studies should be considered to identify at-risk asymptomatic brain territories. And finally, we suggest to use imaging methods most familiar and available depending on individual institutions. PICO 2. In patients with MMA, does the assessment of involvement of posterior circulation compared with no assessment improve the identification of patients at higher risk of unfavorable outcome? We could also not provide here any recommendation, but in children, we suggest assessment of PCA or posterior circulation involvement to identify patients at higher risk of stroke and cognitive impairment. And we suggest the same method to be used, but to identify patients at higher risk of ischemic or hemorrhagic stroke. PICO 3, in patients with MMA, does genetic testing of the RNF213 susceptibility variants compared with no genetic test improve the identification of patients at higher risk of unfavorable outcome? There is no evidence for any recommendation, but our expert consensus statement is regardless of ethnicity, we suggest against systematic screening of the most frequent variant of RNF 213. What about antiplatelet therapy? PICO4. In patients with MMA, does antiplatelet therapy, compared with no antiplatelet therapy, reduce the risk of an unfavorable clinical outcome? Only the following expert consensus statement was provided, suggesting the use of long-term antiplatelet therapy to reduce the risk of embolic stroke in patients with non-hemorrhagic presentation. Concerning now the surgical treatment, PICO5, in patients with MMA, does revascularization surgery compared with no surgery reduce the risk of an unfavorable clinical outcome? We could here provide a recommendation only for adult patients with hemorrhagic presentation. And our recommendation is, in adult patients with hemorrhagic presentation, we recommend revascularization surgery in case of cerebral hemodynamic impairment and in presence of choroidal collaterals. The quality of evidence is low and the strength is weak. This recommendation was based on the only one RCT available in Moyamoya angiopathy, which is the GEM trial. 80 adult patients were included and randomly allocated to medical treatment or combined revascularization surgery on both sides. A lower rate of recurrent cerebral hemorrhage was observed in the surgical arm, but the quality of evidence of this study is low due to no blinded allocation of participants, the optimal size which was not met, and the limit of significance. Outside the hemorrhagic presentation, we also had expert consensus statements, and for this important question, we obtained a full and consistent agreement among the voters. For all patients, we suggest that surgical revascularization is performed in a referral center and by a neurosurgeon with significant experience in surgical revascularization techniques. In adult patients with ischemic presentation, we suggest revascularization surgery in case of clinical symptoms and or imaging markers of hemodynamic impairment. And in asymptomatic patients, we suggest conservative treatment except in patients with both cerebral hemodynamic impairment and silent ischemic lesions in the same cerebral region. And for pediatric patients, we suggest revascularization surgery when evidence of ongoing ischemic symptoms or cerebral hemodynamic impairment. In support, we have 5 observational studies comparing revascularization versus conservative surgery in adult ischemic MMA. The meta-analysis that we did evaluating the risk of any stroke showed, as you can see, a clear trend in favor of surgery. But this is important to note that all these studies had several limitations. Regarding the revascularization techniques now, PICO6. In patients with MMA, does revascularization surgery compared with no surgery reduce the risk of an unfavorable clinical outcome? There is no evidence for any recommendation here, but this is our expert consensus statements. In adult patients, we suggest direct or combined revascularization instead of indirect strategies for reducing the risk of stroke. And in pediatric patients, we suggest combined revascularization instead of indirect strategies whenever technically possible to decrease short-term risk of stroke. In support, we have 5 observational studies comparing direct or combined versus indirect revascularization in adult MMA, and the meta-analysis evaluating the risk of any stroke showed a clear trend in favor of direct or combined revascularization. But again, these studies had several limitations. Antiplatelet continuation during surgery, ECO 7. In patients with MMA, does discontinuation compare with continuation of antiplatelet therapy during the revascularization procedure increase the risk of an unfavorable clinical outcome? No evidence, of course, but we suggest during bypass surgery, continuation of antiplatelet treatment as monotherapy is safe. In case of discontinuation, we suggest restarting antiplatelet therapy 1 to 7 days after surgery, depending on the post-surgery CT scan. In case of dual antiplatelet therapy, we suggest stopping the other second antiplatelet therapy for 7 days before surgery. In practice, what about the time interval between stroke and surgery, ECO 8? In patients with MMA, does respecting a 6 or 12 weeks minimum time interval from an acute cerebral vascular event to revascularization surgery compared to earlier and or immediate surgery reduce the risk of an unfavorable clinical outcome? We suggest waiting 6 to 12 weeks from an acute cerebrovascular event before performing surgery to reduce the rate of postoperative complications, to avoid trigger factors such as dehydration, fever, and hyperventilation, as well as hypotension when waiting for surgery. In children, we suggest that waiting for surgery should be balanced against the risk of further stroke. And in these pediatric patients, we suggest that early surgery would be considered for those with recurrent TIAs, single or recurrent ischemic strokes, if there is a rapid and complete clinical recovery. Moving now to the long-term follow-up after conservative or surgical treatment, ECO 9. In patients with MMA, both after surgery and with conservative management, does long-term follow-up neuroimaging assessment compared to no follow-up assessment modify the clinical practice in terms of medical or surgical treatment? Our consensus statements was as follows. We suggest long-term neuroimaging follow-up to evaluate the progression of the angiopathy. In case of unilateral MMA and conservatively managed patients, neuroimaging assessments should be carried out. Neuroimaging follow-up should include at least MRI, and hemodynamic evaluation. DSA should be performed preferentially when a vascular chain is suspected and the therapeutic decision is to be made, or when non-invasive techniques are not conclusive. Finally, we suggest that the timing of follow-up assessment should be individualized. To conclude, this is the third guideline on the management of MMA using graded methods. As you can see, we found an overall paucity of data on diagnosis and effective treatment approach. We found mostly observational studies, and only one specific RCT was available. Finally, we provide one evidence-based recommendation with low quality of evidence on surgery and non-expert consensus statements. Thank you very much for your attention.